Hi, my name is David Gomez. I am in the Infinitus Medical Technologies office today. Today I wanted to go over brief education on using intubation boxes like the IntubationPod from Under the Weather as it relates to how we position patients in the operating room. Real briefly, I just wanted to give you a background. This type of pad represents foam pads that are used for lithotomy and or Trendelenburg procedures today. They all tether down at the end of the table, and once the patient is in the correct position like this model is here, then we would facilitate lithotomy. But you see the difference between the patient's head to the end of the table on new tables that maybe have a 45-inch torso section minus the headpiece, which means that we physically have to lift and move these patients all the time. The way we've always kind of done it and just accepted it in the industry is because we didn't want to lift patients by sheet and by hand off surfaces that had friction to them. We would pre-position them down there and then intubate from a distance. That is no longer going to be a standard of care as it relates to securing the airway and reducing aerosolized vectors like COVID-19. So this would require the patient's head to always be at the top of the table so we can facilitate that, and we'll show that in the next video. But afterwards, we would have to, once the airway was secured, we would have to lift and move that patient by hand and sheet. We're going to show you a completely better way to do any of that stuff using our Genesis systems. Thank you very much. I just wanted to go over how our Genesis system can help facilitate better approximation to the patient's airway to anesthesia when utilizing boxes, intubation boxes like the one here from Under the Weather. So what we would do is we would place our system, and we have the only positionable pads on the market. We would place our system at the top of the table, even if you're going to require lithotomy, and we'll show you how easy that's going to be here in just a few moments. But we would facilitate that patient at the top, so that way we can intubate the patient using a box like this to reduce aerosolized spread of things like COVID-19. So what would normally happen is, the anesthesia provider would have direct access to the airway, manage the airway in a way that reduces aerosolized spread by having a good mask seal during pre-oxygenation. And then once the patient is induced, then she would put the endotracheal tube in and then secure that endotracheal tube. And once the endotracheal tube is secured, then what we would do is put a filter like this, which is a standard anesthesia filter, over the top. So that way when we move and lift our patients before we connect that ventilation tubing to them, we again decrease the risk of aerosolized spread because patients will passively pass some of the aerosolation that's in their lungs with an open tube. And we'll demonstrate that here in just a second. Now we're going to show you how easy it is to position the patient after we've intubated the patient. We have a viral filter on the end of the endotracheal tube. At this point, we'll also have ventilation circuit on there while we get ready to transition to tuck the arms. Once we finish tucking the arms, then we'll lift and move patient down there with the handles that we have, and then we'll reconnect the tubing. So here's what we're going to do. Right now, the patient's ventilated. We're going to tuck the arms. We're going to show you how we can tuck the arms over using a draw sheet. So we tuck his arms this way, so there's no more draw sheet, there's no more rolling a patient back and forth. And that's all we do. We remove this arm board. We're going to do the same over here. There we go. Once the patient's arms are secured, then we use our handles, and we're going to lift and move both patient and pad. So what we'll do is we'll disconnect the end, because as we move patients, they'll passively exhale, so you want to protect everybody in the room. Before we do that, we're going to go ahead and remove this hood, making sure we don't knock the airway out. We will lift on the count of 3 and move about 14 inches to lithotomy. 1, 2, 3. We'll connect the tube back up and we'll ventilate our patients. And then what we'll do is we'll put our chest pad and our chest strap on per our video and IFU, and then secure the patient accordingly. At the end of the procedure, what we can do is reverse this step. Since we're going to need to extubate our patient and again protect the staff from aerosolized spread of COVID-19 and other vectors of virus, then what we'll do is we will, once the legs are down from lithotomy, we'll lift and move both patient and pad back up. 1, 2, 3. And then we'll disconnect the ventilation tubing, put this back into place here. We'll run the ventilation tubing back in here and follow extubation protocols per anesthesia as we normally do, and again, contain all the aerosolized spread of what we have here. That concludes how our systems work and how they will facilitate these processes in the post-COVID-19 world. Thank you very much.